Good morning, everyone. I'm Roger Carter, and I'm the HFMA Director of North Florida Education. Welcome to the Region 5 HMA Virtual ANA Education event. For those who did not attend the last session, this is our third ANA event of this year. It's our goal to host 3 to 4 ANA events every year to help our members achieve their CPA requirements. It's my pleasure to kick off the second session of the day, Community Benefit Reporting 501R. Before we get started with the presentation, I have a few announcements to make. First, I want to take a minute to thank all of our Florida HFMA chapter sponsors. Without them, we would not be able to offer these fantastic virtual education events. I'm sure all of you are now experts at virtual events, but as a reminder, if you need CP credit, you will need to stay on for the duration of the presentation, as well as answer polling questions, all of the polling questions, to get credit. If you have only dialed in via phone, unfortunately, we would not be able to track your attendance, so please log in using the link located in your calendar invite. You will receive a post-event survey, generally within 48 business hours, that will contain the link to the recording, feedback survey, and certificate. Also, please feel free to add any questions to the Q&A box during the presentation, and they will be addressed at the end of the presentation if time allows. However, if time expires, we will give the questions to the presenters so they can respond back to you via email. Now, I would like to introduce our presenters, Brittany Kojak, Gina Ardillo. Both Brittany and Gina are leaders in the Crow tax practice and have a wealth of knowledge and are true professionals. Thank you from the chapter, and please feel free to tell the attendees a little about yourself. The floor is yours. Thank you.
Well, good morning, everyone. It's nice to be here with you today. My name is Brittany Kojak. I'm a tax partner in Crow's National Exempt Organization Services practice, and I'm joined today by Gina Ardillo, a manager in our practice as well. We're going to share with you information about community benefit, Section 501R, and community health needs assessments. We certainly would love to make this interactive. It looks like a small group of participants, so if you have any questions, certainly don't hesitate to either come off of mute and ask your question or submit through the chat. We're happy to talk with you as we move along. So in today's session, we're going to cover an introduction to community benefit, how it all came to be in regards to the community benefit standard in Section 501R. We're going to provide an overview of the community benefit categories, talk about the CHNA requirements. Most organizations are just beginning their next cycle in regards to completing the community health needs assessment. So we'll talk about what we expect to see for trends for this round. And we will conclude the presentation with a discussion around a comprehensive approach to uncompensated care. So moving forward, just as an introduction, the history of the community benefit standard. Revenue ruling 69-545 was really the first time that a hospital organization had requirements in regards to becoming a tax exempt organization. And in order to maintain 501c3 exempt status under revenue ruling 69-545, a hospital must operate an emergency room that is open to all regardless of ability to pay. Must maintain a board of directors that is drawn from the community, maintain an open medical staff policy, provide hospital care for all patients that are able to pay through programs such as Medicaid and Medicare, use your surplus funds to improve facilities, and also use your surplus funds to advance medical training, education, and research. So those are really the basis for tax exemption for hospitals. The evolution really has been a number of things that have led us to where we are today. Senator Grassley has been very active in this area, early on asking questions about hospitals and why they deserve tax exempt status. In July 2007, the Senate Finance Committee, led by Senator Grassley, put forth a proposal asking hospitals to quantify the community benefit that they provide. And at that point, he proposed that no hospital can maintain 501c3 exempt status without dedicating a minimum of 5% of its operating revenues or expenses to charity care. And so fast forward to today, there's not a bright line test in regards to the amount of charity care and community benefit that's required, but most refer back to that 5% threshold as sort of a guideline in regards to how much you should be providing as a minimum. We also saw a Government Accountability Office report. Congress asked the GAO office to examine the IRS's community benefit standard and state requirements, along with guidelines nonprofit hospitals use to define community benefit. So that was 2008. The Provena case is still talked about today. Back in 2002, Provena applied for property tax exemption in the state of Illinois. And the Illinois Supreme Court ended up deciding that because Provena's cost of charity care was so low, Provena was not entitled to a property tax exemption as a charitable institution based on that low amount of community benefit being provided. We've seen other states as well follow this pattern. In 2015, Morristown Medical Center in New Jersey experienced a similar conclusion. And they now are paying property tax on a fourth of their property. Fast forward to recently in Florida, Florida House Bill 1175 was originally proposed that community benefit reporting would be done on an annual basis by hospitals, and you'd have to equate your property tax exemption to the amount of community benefits that is being provided. Luckily this year that was repealed by Governor DeSantis, but certainly the states are looking at community benefit provided by tax exempt hospitals to make sure that they are in fact deserving of not only their income tax exemption, but also their property and sales tax exemptions as well. 501R was added to the Internal Revenue Code as part of the Patient Protection and Affordable Care Act. And you can see on this slide some of those requirements in regards to conducting a community health needs assessment, having a financial assistance policy, limitations on charges, and billing and collection provisions. So this has been an evolution of the community benefit standard and really continues to evolve. But why is it important? As I mentioned, tax exempt hospitals must show that they benefit the community and the public by promoting the health of the community, not only from an income tax perspective, but as I mentioned, property tax has been heavily scrutinized, as well as sales tax exemptions as well. And so fast forward beyond the history I just provided, even just as recent as last year, Congress asked the Government Accountability Office again to review the IRS's implementation of these requirements. And the most recent GAO report talks about not only their findings, but also recommendations back to the IRS. So for those that aren't familiar, as a result of the GAO review, they've made 4 recommendations to the IRS: that the Form 990, including Schedule H, be updated, that hospitals be required to compute community benefit hospital by hospital, that the IRS establish a well-documented process to identify non-compliance with the community benefit standard, and then that the IRS establish specific audit codes for identifying non-compliance with the community benefit standard. So again, this continues to evolve. Congress is focused on making sure that tax exempt hospitals are in fact deserving of that exemption. And so the basis of our presentation today is really just sharing with you an overview of what counts as community benefit, what you should be thinking about as a hospital organization, and moving into your next CH&A cycle, how that can have an impact on what's being reported. So now I'm going to turn over to Gina, who's going to cover some of these categories in more detail.
Thanks, Brittany. So to get started at a high level, what is community benefit and how do you quantify it? When you think of the relationship between community benefit and the activities of a healthcare organization, generally those activities must be responding to a demonstrated health-related need in your community in order to be counted as community benefit. So that's where your community health needs assessment really comes into play here. It's an important part of this process of reporting community benefit, because everything you report as community benefit really needs to tie back to a reported health need of your community. And it also must seek to achieve at least one of these objectives listed here, being improving access to health services, enhancing public health, advancing knowledge through education or research, or relieving or reducing a healthcare burden of the government or other tax exempt organization. So on the next slide, we show a screenshot of the Form 990 Schedule H, Part 1, Line 7, which is where we see community benefit activity reported. The grid reporting this from the 990 is shown on this slide. Over on the left here, we have your categories of community benefit. And in the following slides, we'll walk through each of them at a high level, what each of them mean, what's included, and what to look for when you're pulling that information together. So we'll start by talking about the two financial categories of community benefit. The first category we'll jump into is financial assistance. Financial assistance is defined as free and discounted healthcare services provided to persons who meet certain criteria is laid out by the organization in your financial assistance policy. Now, those criteria can be different from organization to organization, but if you receive services from a hospital and you meet the criteria that that particular hospital has laid out in its financial assistance policy, and you're deemed unable to pay for all or a portion of the services that you received, you'll receive financial assistance. So what gets reported on the Schedule H is actually the cost of the financial assistance to the hospital. So in fact, everything that gets reported on Schedule H, Part 1, Line 7, as community benefit is ultimately getting back to the net cost or expense to the hospital. And so what you'll look for is those patients who've met the criteria to qualify for financial assistance. You'd expect to see an identifier or a code or something for each of those patients indicating that that the account is a financial assistance account. So the patient's account will, of course, show patient charges that the patient didn't pay, but for those accounts, we're reporting the cost of those services as community benefit under the financial assistance category on Schedule H. So the next one we'll talk about is Medicaid and other means-tested programs. So with Medicaid, your reimbursement for Medicaid will almost never cover your cost. The only times historically where we've really seen a Medicaid surplus is for a hospital who serves a disproportionately large population of low income or Medicaid eligible individuals as compared to other hospitals in that area. So those hospitals aren't getting surplus funds from commercial payers. So sometimes Medicaid will reimburse those hospitals at a higher rate to help cover costs. Usually Medicaid reimbursements won't cover the entire cost and you'll see a shortfall reported, which is a cost to the hospital and increases your community benefit reported. Other means tested government programs, most common will be your children's health insurance program, just government programs that provide benefits or coverage to families with children if those families meet certain eligibility criteria. So recent development in the world of Medicaid. So after I just talked about how we almost always see Medicaid shortfalls reported on Schedule H, that trend might start to look a little different here soon, thanks to Florida's new Medicaid Directed Payment Program, or DPP. The Medicaid DPP is an effort by Florida to help address the ever-increasing gap between the cost of care and reimbursements received from Medicaid. Since the start of the COVID-19 pandemic, Florida has seen almost 1 million new Medicaid enrollees. So that puts Florida's total Medicaid enrollment at almost 5 million. That significant of an increase obviously has put a strain on Florida's Medicaid budget, given that more enrollees means a higher cost to administer and deliver services to Medicaid beneficiaries. So Florida lawmakers have been in a particularly tough position here, and they've acknowledged that reducing Medicaid payment rates to hospitals might be a necessity for budgeting purposes. So obviously that just adds to challenges that hospitals are already facing, trying to make sure that those vulnerable populations are receiving adequate care, which has already become more difficult with the pandemic. So really just lots of compounding barriers to providing quality care hitting these hospitals at the same time as a result of the pandemic. So the Medicaid DPP program was born to help combat those issues. And this program allows local governments to establish a special assessment charged to hospitals, and the amounts collected through that special assessment are placed into a local provider participation fund and are matched with additional federal funding that is then remitted back to the hospitals to help close that gap between the cost and reimbursement of care provided to Medicaid beneficiaries. So the intent is certainly to help ease hospitals' financial burden of caring for Medicaid patients, but we'll be interested to see what those reimbursements do to community benefit reporting of those hospitals who are participating. So that actually brings us to our first polling question. What impact will Florida's Medicaid DPP program have on your community benefit percentage? Significant impact on Medicaid shortfall, small impact, not sure, or your hospital is not participating.
And we did get a question come through the chat that I'll read while we wait for folks to answer the poll. It looks like it was noted that it's similar to Washington State's program, where other states have a provider tax. This is similar. It will be reported as a provider tax, but the difference here is that after you pay into the Medicaid DPP, the payment back to hospitals is expected to be larger than the provider tax you're paying in. So it's actually additional reimbursement to the hospitals, which is why we're expecting your shortfall to decrease. And I've gotten a comment that's exactly how the programs work in other states as well. So that may be true. I'm not familiar with Washington. I know Texas has the DPP already.
I think there's a few other states with the DPP at this point.
Mm-hmm. So are we finished with the poll? Do we see results at this point, or are we still waiting for completion? Okay.
Okay, interesting. All right. So moving on to the next slide, we'll move into the non-financial categories of community benefit. So these activities are things that hospitals do that don't necessarily generate a patient bill, but they generally come at a cost to the hospital. And so those activities might be considered community benefit. The first one of these non-financial categories is community health improvement services. Now there's a wide variety of activities that can fall into this category. Things like education, health fair support groups, providing transportation for people who have a transportation need. This could also include post-discharge services to homeless individuals. So again, this goes back to health needs that have been identified in the community, which that might include socioeconomic needs. So for example, if you were responding to that type of identified need by operating, say, a housing initiative, that would fall under community health improvement services. Telehealth might also fall into this category, but again, only if it is responding to an identified need in the community. So if your hospital is located in an underserved community, or if your hospital has specialists providing telehealth to more rural areas of the state, those types of services might qualify as community benefit under community health improvement services. Next, we'll talk about subsidized health services. Subsidized health services are services that will generate a patient bill, but in total, the services also generate a financial loss to the hospital. A service meets the definition of a subsidized health service if that service is otherwise unavailable in the community, or the community's capacity to provide that service would be below the community's need for the service, or the service would be otherwise the responsibility of the government or another tax-exempt organization. There's a lot of judgment in figuring out what you can include in community benefit for subsidized health services. It's not really black and white. So the next slide will show some specifics that you might be able to include in this category. Some of the more common services you might want to consider reporting here are like a life flight or an air ambulance or even a ground ambulance. So those emergency services that generate a loss where the hospital loses money, those can fall into the category of subsidized health services. Some others are clinics for low-income individuals, hospice and certain palliative care services, renal services, both inpatient and outpatient mental health services. Something to note is that just because a clinical service line produces a loss, it doesn't automatically make it a subsidized health service that you can report as community benefit. Again, it all ties back to identified health needs in your community. So for instance, a hospital might open a new unit or start a new program that generates a loss in its first few years. If the services provided as a part of that program don't tie back to an identified community health need is noted in your CHNA, then that loss should not be included as community benefit, should not be included in subsidized health services here. So you'd always want the service to tie back to a need identified in your community health needs assessment to include it as community benefit here. The next slide shows a few more services that might count here. Another area where there's some judgment required is with mobile mammography. So a lot of times those services will produce a loss, but you have to look a little further. You have to ask, is this mobile mammography provided? Is a convenience to our patients? Those patients come to our physicians or our hospital for other services. So we're really just providing this as an option, as a courtesy or convenience, versus is your mobile mammography going out to underserved populations to provide services that otherwise would be unavailable to those patients. So if that service would be unavailable, that latter example, that would qualify as community benefit. But the first, where it's really more of a convenience, that would really just be more cost of doing business or marketing for the hospital. We've already talked a little bit about telehealth, and there's some other items listed here that you just might want to review against the needs identified in your CHNA to consider, including as subsidized health services in your community benefit reporting. So here we have a few examples of things that do not count as subsidized health services, just to give you a little more insight into the bigger picture of how to be thinking about community benefit reporting for subsidized health services. So as we've already discussed, service lines that create a loss for the hospital are not subsidized health services if that service line is not a documented community health need. So on-call physicians. So sometimes we see hospitals that outsource their ER, their emergency room, to a third party like a physician group to provide those emergency services. And if the emergency department has an overall loss, those services could still qualify. However, if you provide services, if you provide payment to independent physicians to care for patients in your ER who qualify for financial assistance under your financial assistance policy, so that could include even physicians who treat patients who come to your ER with a condition that is less severe than what would be considered a true emergency. Either way, whether it's someone in your emergency room or an inpatient unit, inpatients are made to independent physicians treating individuals who qualify under your financial assistance policy. Those should be reported as charity care rather than reported as subsidized health services. Also, services that are typically provided as a part of the standard of care. So the example on the slide here is a rehabilitation hospital. It's typical to provide housing, patient and family education, training, post-discharge services. Those are just services that are part of the standard of care, and you can't break those out to be reported as community benefit. And then there are ancillary service departments that are really more like supporting service lines, like radiology, anesthesiology, a lab. Those departments are always going to generate a loss because there's nothing really coming in specifically to those departments because they're a part of a larger service line. So each of those more supporting type services are feeding into things like cardiac care or oncology or other specialties or service lines, and you can't break those out for community benefit either. So let's move on to health professions education. These are educational programs that result in a degree, a certificate, or training necessary to be licensed to practice as a healthcare professional as required by state law. It does not include education or training programs that are exclusively available to your employees. So ongoing training programs that are only available to your medical staff do not count as community benefit for health professions education. So what does count? What we're looking for, if we flip to the next slide, what does count? We're looking for medical and nursing schools and costs associated with those, all costs that are associated with precepting or clinicals or mentoring students in the healthcare world. We're also looking at opportunities provided to students pursuing the medical field in other health professions like dietitians, lab techs, physical therapists, social workers, pharmacists. You've got a whole wide range of other health professionals who receive clinical training in a hospital setting. And so for clinical and mentoring programs, you're also capturing some of the time of the professional themselves. So like if there's a nursing school nearby and your hospital provides clinical rotations for the school's nursing students, and say a nursing student comes in to shadow a nurse for a shift, you're capturing typically that the experienced nurse is not as efficient during that shift as they would be without their student shadow. So you can account for the fact that the experienced nurse might be losing a certain percentage of their work capacity in order to train the student. And then lastly, scholarships or tuition payments to health professionals for health professionals can be included as community benefit as health professions education, as long as the benefiting individual is not an employee of the hospital and there's no contingency required, no contingency requiring the individual to work for the hospital as a condition of that scholarship or tuition payment. Next category is research, which is just the study or investigation that receives funding from a tax exempt or government entity, where the goal is to generate generalizable knowledge that's made available to the public. So really the key here is that the research cannot be used only for private purposes. The research needs to be made publicly available in order to count as community benefit. And then the last two groups on community benefit are your cash and in-kind contributions. So your contributions that you provide out to other organizations that are health related. So this wouldn't necessarily be, donations to your kid's little league team or to the shelter where you adopted your cat. This would really just generally be for contributions to health related nonprofits. And again, it should tie back to community needs identified in your community health needs assessment. And then any costs associated with operating your community benefit department can be counted as community benefit as well. So typically you'll have community benefit leaders who oversee your community benefit programs, overseeing your CHNA, their salaries, benefits, things of that nature can be captured as community benefit. So that wraps up the community benefit piece that is reported on Schedule H Part 1, Line 7 of the 990, but you also have this group of items that are reported on Schedule H Part 2, known as community building. So I won't go into the same level of detail of these categories, but I think the main takeaway here should be that there could be some overlap between community benefit and these community building activities, where you might want to think about if anything that would normally fall under community building might be able to be reported as community benefit instead. So if we call back to a previous example that we talked about, your hospital might be involved in housing initiatives in your community, which could certainly fall under community building. And in fact, typically that's where we would see it, under community building. But if housing or economic development is identified as a need in your CHNA, like economic development might be a need identified for an impoverished area, those costs could potentially work their way into being included in community benefit reporting instead of community building. So with that, I will pass it back to Brittany to talk about CHNA requirements.
Thanks, Gina. So we will start off this section by a polling question. The question is, has your organization started its 2022 CHNA process? So yes, we've started, no, not yet, our hospital is on a different cycle, or I'm not sure. So we'll give the audience a minute to answer that question. And if our moderators could let us know if we've got results just yet. Okay, so across the board, some have started, some have not, and some are not sure. Okay, very good. Well, we are going to spend a few slides here covering the CHNA process. As you've heard from Gina, it does correlate very closely to community benefit reporting, because having an identified health need is part of the requirements in order to count as community benefit. The CHNA requirements are part of Section 501R, which again, as I mentioned, was added to the Internal Revenue Code as part of the Affordable Care Act over a decade ago. And the requirements are that each hospital facility conduct a CHNA and include the following: a definition of the community that it serves. You must assess the health needs of that community. In assessing the health needs, solicit and take into account input from persons who represent the broad interests of the community, including those, and this is important, including those with special knowledge or expertise in public health. And when you complete that process, you document in a written report that ultimately is adopted by an authorized body of the hospital facility, typically the board of directors or a committee of the board. And once you've gotten the report authorized by the board, you then follow up by making it publicly available, typically on your website. So in regards to the actual requirements of the CHNA, and I mentioned some of these previously, the CHNA report must include the following items: a definition of the community served and a description of how the community was determined. So there's no requirement on how you determine your community. Some use zip codes, some use county level information, but you certainly have to define the community that you serve and describe it in the report itself. You have to include a description of the process and the methods used to conduct the CHNA. You need to include a description of how the hospital facility solicited input from persons who represent the broad interests of the community, whether that be survey data that you've collected, interviews of key stakeholders, whatever may be the case. You certainly have to describe how you collected input and what those results show. You then need to include a prioritized description of the health needs and the description of the process and criteria used in determining which ones are the prioritized health needs. And finally, a description of resources potentially available to address those health needs, as well as an evaluation of the impact of any actions that were taken previously. So this is just an example of a CHNA work plan. For those that are in this area and work through the CHNA process, this is our fourth cycle that is required now by the Affordable Care Act. So most have a work plan in place, but we also work with hospital organizations to conduct CHNAs as well. And so this is an example of a work plan we have developed in regards to planning the process, the data collection phase, gathering community input, and then finally development and presentation of the report itself. For most hospitals, they'll be required to conduct their fourth CHNA by the end of their fiscal year ending in 2022. So certainly now is the starting point for many organizations as they're planning and working through that process. So what are we seeing in regards to trends? This is just highlighting the first cycle for most organizations was 2013. And that was really just the first year that the rules became effective after the Affordable Care Act. And back in 2013, we saw most organizations identified some of the key health needs in their area: cancer, obesity, diabetes, stroke. Those were some possible, themes that we saw. Fast forward to 2016, we started to see things like behaviors coming through as health priorities, healthy eating, exercise, substance abuse. In the most recent CHNA cycle of 2019, more and more organizations were focused on mental health and lack of mental health providers. We also saw organizations focusing on children's health and senior health. So going into the 2022 cycle, what do we expect? One of the areas hospitals have really begun to focus on is social determinants of health. And so, social determinants of health are the conditions in the environments where people are born, they live, they learn, they work, that affect an individual's health. And so social determinants of health do have a major impact on people's health and on people's well-being. Some examples can include safe housing, transportation, racism, violence, education, polluted air and water, language and literacy skills. So some of those are just examples of social determinants of health, but we're really seeing focus by hospitals on these areas and expect that to be a key theme in the upcoming CHNA cycle. In addition, we're expecting to see that hospitals are able to utilize more robust data. Because there is so much more data available today compared to previous assessment cycles, hospitals may want to utilize that data And by robust, I don't mean that there's a listing of 300 health indicators in your assessment. What I mean is that hospitals will be looking to gather information on health conditions by race and ethnicity, by age and location, as opposed to reviewing data for the population as a whole. And so I think this data is going to be a lot more insightful, certainly in regards to health disparities. And so we do expect that to be a theme for this next upcoming cycle, is just the use of more robust data. And finally, review and update key stakeholders. Similar to new and evolving data sources, we also see that organizations are challenging which stakeholders will be included in their CHNAs. In addition to social service organizations, large employers, schools, representatives from the faith community, and those that are serving vulnerable populations certainly may be included based on the increased focus on addressing the social determinants of health. So those are some of the themes that we're expecting in the upcoming CHNA cycle. Certainly would be curious to hear from the group if those line up with where your hospital is going as well. So this is just a slide showing community benefit trends. The data is a 5-year look up to 2018. This is based on Form 990s that are publicly available. And so 2018 is really the most current year in which nearly all 990s are public. So what we saw is that there were quite a few hospitals that reported less than 5% community benefit in 2018. There also were a number that reported more than 10%, so certainly a wide range. But I would certainly advise those 532 that were low on their community benefit percentage to consider doing a deep dive into some of these categories that we've talked about earlier, just in regards to beefing up and perhaps optimizing that community benefit reporting. Additional data that we thought would be interesting, each of these bars represents the size of a hospital organization. So hospitals under 100 million in revenue, 100 million to 500 million, 500 million to $1 billion, and over $1 billion. And so you can see the larger the hospital, typically the larger the percentage of community benefit. And so you also can see here, based on the various colors, the types of community benefit being offered. And so in those largest hospital organizations, the subsidized health service bar tends to be smaller, but some of the other bars tend to make up for that. This is just some data in regards to expansion states versus non-expansion states and where the components line up. Again, the colors match each of the categories, and you can see in non-expansion states, there's quite a difference. And so we've highlighted that for you here as well. So moving to the end of our presentation, we certainly advise a comprehensive approach to uncompensated care, and really just taking a step back as you enter this new CHNA cycle to look at not only how you conduct your CHNA, but also how you approach uncompensated care overall. What we have here is just a diagram showing the interplay between all of the reporting bodies for uncompensated care. So not only is the Form 990 a reporting tool, but obviously many states have state and local filings where you report community benefit. Your audited financial statements certainly required to cover the cost of community benefit and charity care. The worksheet S10 obviously has a component, and then any community benefit reporting. So again, connecting the dots here and making sure all of the various reporting cycles have the same information. As you evaluate your community benefit, and certainly for those 500 hospitals that may be on the low end of the spectrum, there is the opportunity to optimize what's reported. And so I would advise that you take a comprehensive approach to doing that, where you consider not only the 990 and tax reporting that's associated, but also how does that impact your reimbursement from a cost report perspective? Does additional charity care put you in a position where you're able to receive additional types of reimbursement? What does that look like from the perspective of your community benefit report? And really just taking an overall approach that's comprehensive as you evaluate each of those categories and what you're reporting. So I have a final polling question for the group today. Has your hospital considered a multidisciplinary approach to community benefit reporting? And so the answers are yes, that multiple departments collaborate, no, and you're not sure. So we'll let the group respond to that question. And we'll give you just one more second while results come in. We can see those results when they're ready, please. Okay. So about half of the folks are in fact indicating that multiple departments collaborate. For those that answered no, certainly would be happy to talk more with you about the opportunities there. And then some are just not sure. So we've wrapped up our prepared presentation, but we certainly are available to answer any questions. I know we've ended a little bit early, but for CPE purposes, I believe we need to stay on for another few minutes. So if there are questions, we'd love to entertain those. So I will open it up. Any questions from the group? Okay, very good. Well, I think that's all we had for today. Do our moderators have anything to add to the end?
Yeah, hi, Brittany. Maybe you could possibly discuss if there's any issues with computing costs or anything like that when it comes to like excess Medicaid costs over reimbursement. Are there any issues you're seeing out there with people potentially calculating that incorrectly?
We actually do see a lot of area for improvement, quite frankly. In tax reporting and is often used for the other reporting mechanisms as well, you typically use a cost to charge ratio where you start with your gross charges from Medicaid and charity, and you use a cost to charge ratio to get down to the cost of care. But how you get that cost to charge ratio certainly has some room for improvement. For 990 purposes, we would not recommend using the cost to charge ratio because it can be quite different than the IRS worksheet 2, which gives you a different formula for getting the cost to charge ratio. So certainly something to consider if you haven't looked at doing an analysis between the two options. Certainly something to think about, because if your cost to charge ratio changes, that can in fact move the needle on community benefit. So that would be one area. But we work with hospitals very closely in regards to just optimizing all of these categories of community benefit. So making sure that you've captured all the programs that you can capture within those programs, capturing all the costs associated. So, not only the programs themselves, but the administrative costs, both salaries and fringe benefits for those that are involved. So we do find opportunities quite frequently to really dig into what's being reported and perhaps bump up those numbers a bit if you haven't already done a deep dive.
So I'm just trying to make sure we've got enough time in here, but have you also seen any organizations receive any significant maybe penalties or whatnot for not meeting that community benefit threshold?
The IRS has not been as focused on the percentage itself, but I think what we're expecting is that they will going forward based on the GAO report. But what we certainly have seen is IRS enforcement of the 501R requirements. And so if you fail to conduct that community health needs assessment or fail to make it publicly available, the penalty for that would be a $50,000 excise tax per year. We do see on a regular basis that hospitals have either just not reported it on their website or perhaps didn't get it board approved. And so I would suggest for those on the line to confirm that you've met each of those steps in conducting the CHNA. just because that penalty can be so high. And obviously you only do the CHNA once every 3 years. So the 50,000 would be times the 3 years. So certainly something to be aware of in regards to the excise tax, that if you don't follow all those requirements, you can get hit. For the other components of 501R, the financial assistance policy components and billing and collections, there's not a monetary penalty for failure to comply. However, the IRS can certainly revoke tax exempt status. And so that would be a worst case scenario, quite frankly. So you don't want to find yourselves in a position to be discussing that with an agent. So certainly something to be thinking about in regards to making sure that you are compliant.
I'm going to try to keep you going a little longer here, Brittany.
Sure.
Obviously you're an expert in this, and I'm sure you've done many of them, but are you seeing a lot of organizations try and tackle this themselves, or are they, looking to professionals like yourself to really kind of navigate them through the process? Because I mean, as I'm going through your presentation and listening to you, I'm having flashbacks of, dealing with this 10 years ago. And it's like, oh man, I do remember all of this. And it's pretty difficult to really, pull a lot of that information together and just make sure you've got everything, because there's so many different areas and, not-for-profit providers. And when it comes to volunteers and just, you're lending out your meeting space to other not-for-profit providers. And it is really difficult to try to make sure you're capturing all of that.
Mm-hmm. Yeah, typically hospital organizations have pretty good community benefit departments that know these rules. But what I would say, what we typically see is that the folks in community benefit are often more focused on actually, which is excellent, obviously doing good for the community and offering the right types of community benefit programs, capturing those, but maybe aren't as knowledgeable about the tax implications of the community benefit side. And so that's where I'd recommend bringing in your tax advisor, just to ensure that all of the good work you're doing is being captured and reported appropriately, that you're getting full credit for what you're doing. Obviously with the CHNA, making sure that you've met all those requirements. Quite frankly, we work with a number of hospitals that ask us to do a review of the CHNA draft prior to finalizing it. And nearly every time we open one, we have observations or findings. So even if you're engaging a health consultant to help conduct the community health needs assessments, those folks may not always be thinking about all of the tax requirements. And so just bringing in your tax advisor certainly would be something that I would suggest to make sure you're covered. Did we get us close enough to the finish line, Roger?
I think we may need another minute or two. I'm not sure. Betsy, do you know when we started and how much time we need? And
we do need 50 minutes, and we started about 3 minutes late. So if anyone has an awesome question for Gina and Brittany from the field, we would look forward to that.
Looks like there is something coming through the chat, but it's just a thank you. So we appreciate that. Thank you. Certainly. Oh, another question. How active in the audits of 501R? I'm assuming that you're referring to perhaps how active is the IRS in auditing 501R. That really is one of their greatest areas of focus. So for tax exempt organizations, any areas where they can collect either penalty revenue or tax revenue is going to be where the IRS is focused. So unrelated business income, 501R taxes that are associated with non-compliance with the CHNA. So we do see a lot of agents focused on 501R. Compliance checks are typically how they start the process. And so not just a full-blown examination, but typically they're started by a compliance check. And a lot of times what generates those compliance checks is that Congress did require the IRS several years back to review every Schedule H once every 3 years. And so behind the scenes, what's happening, and you would not be notified, necessarily, but on it every 3 years, someone from the IRS is actually looking at your Schedule H filing. And if there's anything that jumps out as a result of that review, perhaps a trigger question that wasn't answered appropriately, then you're automatically referred over for either an examination or a compliance check. And so that's really what's triggering a lot of this activity, is just that required review behind the scenes. When a hospital does get a compliance check notice, certainly it's focused on a couple of areas. A lot of times it's either information right off the 990 or off the website. Perhaps your information isn't posted appropriately, or it's not available and easy to find. But whatever the case might be, we are seeing a lot of activity from the IRS in this area, really just to monitor and enforce compliance with these requirements. And I guess I'd add to that, if you find yourselves in a situation where you get a compliance check notice specifically related to 501R, I would absolutely advise that you bring in your tax advisor to help you through that, because what you want to have happen in a perfect scenario is that you answer all of the questions completely and sufficiently to where the agent closes out and moves on. What you don't want to have happen is to provide incomplete responses, or perhaps responses that open another question to where the agent is enticed to open a full examination. So I would absolutely advise bringing in your tax advisor if you find yourselves with a compliance check, just to make sure that you are giving enough information, but not too much to just simply close out and move on. Good question. Any other questions from the group? Okay.
All right. Well, Brittany and Gina, thank you very much. That was a very informative presentation. And again, it certainly gave me flashbacks. If any of you would like a copy of today's presentation, please reach out to the chapter at www.florida.hfma@gmail.com. Before we go, there are several other things that I'd like to mention. Your feedback is important to us as we plan future education events. So please take the session and general feedback survey that you'll receive generally within 48 business hours. I want to share with you the value of becoming an HFMA member. HFMA's all-inclusive one-price membership offers the most relevant resources for healthcare finance professionals to meet today's challenges. For unlimited online education to critical regulatory analysis, HFMA delivers tools and resources you need to simplify and successfully cope with the complex and unending changes taking place in healthcare. It's one of the best ways to network and meet industry experts like Brittany and Gina as well. Please get more information about becoming a member at www.hfma.org. Also, mark your calendars for future Florida HFMA events. You can find more information about all of your upcoming events at the Florida HFMA chapter website. Again, that's www.floridahfma.org. And look under the calendar of events section. Thanks again, and we look forward to seeing you at the next and third session of the day, Capital Markets and Economic Update and Investing for Healthcare Organizations at 1:30 p.m. Eastern Standard Time. Thanks again, and enjoy your break. See you at the next session.